The typical endometrial polyp is a homogeneous, hyperechoic, smoothly marginated, well-defined mass. And this is obviously seen here on this MP display and on these rendered images. We can even see it better. Some places are now doing only 3D evaluation of the uterus and the endometrial cavity without the sonohysterogram. Some places are still doing quite a bit of sonohysterography. So the typical endometrial polyp is a homogeneous, smoothly marginated, hyperechoic, intracavitary soft tissue mass with preferably visualization of a feeding stalk, as we can see in this patient, all three of these. Now here are some unusual polyps that we've seen. Here's a polyp that has a little extra bump on it. Here's a little collection of polyps that look like little chicks lined up in a row. Here's an elongated polyp. Here's kind of very broad-based looking polyps. Here's a polyp with some cystic changes in it. Polyps that look a little more rectangular or tubular. Here's polyps that have different oddly shaped ones. Kind of tubular, here's triangular, rounded, elongated with sort of flattened borders. Here's a broad-based one, here's an odd-shaped one, another one that's shaped like a little hammer. So a variety of shapes. Here's some more unusual ones. Cystic center, here's a one with a cystic center. Here's kind of a bilobed. Here are several different, one patient with several different types and shapes, and kind of a bilobed shape here. More unusual polyps. When we did the sonohysterogram, multiple polyps showed up. Sometimes they look like teeth, like pumpkin teeth, a variety of shapes. Here again, a very patulous kind of a cavity outlining a whole host of variable types of polyps. More unusual polyps. This was a 26-year-old with dysfunctional uterine bleeding, and pathology showed that she had multiple polyps and secretory endometrium at biopsy. Cystic changes. We have to make note of cystic changes. Tamoxifen polyps often have cystic changes, and these are due to this mucinous metaplasia and atypia that occur. So we would like to have a history from the patient, usually breast cancer history, that she was on tamoxifen or some type of a SERM. A cystic polyp may mimic fluid. This looked like perhaps some fluid in the cavity until we put more fluid in and realized that that was a cystic polyp with atrophic changes. And sometimes odd things happen, like in this case. We blew up the balloon and we did see a polyp, but when we pulled the balloon back, we realized that there was a very large polyp, and the balloon was actually blown up inside of this polyp, or pushing it aside, and only after we pulled it back did we realize the extent of it. Now sometimes these polyps come on a long stalk. As we can see here, they can move around, flip around in the endometrial cavity. And also, one little reminder here when we do see endometrial polyps, that on the way out as we exit, we should look for a cervical polyp as well. Here, for example, is a little balloon still blown up, where after we deflate the balloon, we watch for exit, and here we see some extra soft tissue within the cervix here, and that was a cervical polyp. So there is an association of cervical polyps with endometrial polyps. Overall, in about 27% of patients, there is a cervical polyp along with endometrial polyps in 40% of postmenopausal women, and in 40% and in all postmenopausal women on tamoxifen, they found that they had additional cervical polyps, so we should look for them. One little technical point would be that watch the pressure on the cervix. Sometimes we press too hard and we can't see the polyp. It's only after we release some of that pressure that we allow a little bit of the fluid to come around the polyp, and then we can delineate it. Here we're seeing power Doppler. Sometimes we see unusual things, such as a polyp attached to a submucous myoma. So here's the hypoechoic sound attenuating myoma and a polyp stuck on top of the myoma. There are usual and unusual manifestations of hyperplasia. Typically, hyperplasia is a diffuse, smooth endometrial thickening. Pathologically, they're classified as simple hyperplasia, complex, or atypical hyperplasia. The atypical ones, 23% of them progress to endometrial cancer. So it turns out that we really can't differentiate them from endometrial cancer, so they need to be sampled thoroughly. Unusual appearances of hyperplasia would be when they are more focal or asymmetrical or irregular in their outlines, and they have, in 26% of cases, they have concomitant polyps. There is polyp or individual formation, and they can have cysts, and again, would be difficult to differentiate from endometrial cancer. Here's a case of focal thickening of the endometrium. This was hyperplasia, and it had small little polypoid projections. This had to be biopsied. It was focal hyperplasia, as we see here. Now, a submucous myoma is typically a hypoechoic solid mass with acoustical shadowing, and it has a broad-based connection to the uterine endometrial wall and has a covering of endometrium on top of it. Here's another one, hypoechoic shadowing kind of a mass. The atypical myomas are the ones that may not be so obvious where exactly it is connected to the wall of the endometrium. Sometimes they develop cystic changes within. This was an unusual one that had a very thick stalk and projected inferiorly, and it had an area of cystic degeneration. It was kind of difficult to figure out how exactly it was positioned. Typically, they are fairly smooth, but in some cases, in unusual cases, they have more of a whorled kind of a pattern. Another atypical kind of case would be when you have the myoma and sitting on top of it is a blood clot. Another one here with a blood clot on top, causing it to have this kind of a mixed pattern. The Doppler can show us the feeding vessel to the myoma, and then we can, the area of the clot sitting on top of the fibroid would have no blood flow. Now, other unusual things that we can see various formations of blood clots, which of course have no blood flow within them. When we see these kind of scraggly looking soft tissue densities, we can try to break them up with the catheter. We push the catheter back and forth, we suck out the clots, we might inject a little bit of the saline to make them, help them break up. We use a gentle catheter manipulation, and this flushing with saline for moving around blood clots, some kind of mucus or debris or adhesions. We can aspirate the contents and then reinfuse and help break it up. As this happened in this case, this was the balloon, and there was this fluffy soft tissue material on top, and we flushed, reinfused, aspirated, and when we pulled back the balloon, the cavity was then clean. So we flushed it out.